Welcome. We are on Pharmacology multiple choice sessions and we are going to solve some 10 multiple choice questions on this fresh session. So let's start with question number 1. Hemorrhagic cystitis is specific toxicity of cyclophosphamide, methotrexate, doxorubicin, meclorethamine and cisplatin. Hemorrhagic cystitis, please mind well, it's not nephrotoxicity. If it's nephrotoxicity, you would go and choose cisplatin. So it's hemorrhagic cystitis. Is any drug specific for this? Are you getting it? Is the first option cyclophosphamide? That's the answer, cyclophosphamide. Why? Because cyclophosphamide has got acrolein content, and this acrolein content is responsible for this hemorrhagic cystitis. And if you want to stop this particular toxicity, if you want to prevent this toxicity, you can use a substance. Are you remembering the substance? They also ask you many times on multiple choice questions. The name of the substance is Mesna. M-E-S-N-A, Mesna. That's mercaptoethane sulfonate. So cyclophosphamide is the answer for hemorrhagic cystitis. Other options are methotrexate, which is a folic acid antagonist. So you can get folinic crisis. Next one is doxorubicin. This can produce cardiotoxicity. And cisplatin is one of the important agents which is responsible for nephrotoxicity. And other agent is meclorethamine, is an alkylating agent which mainly produces bone marrow suppression. So these are the toxicities of rest of the drugs which are there in the options. So hemorrhagic cystitis, cyclophosphamide. Let's go to the second question. Treatment of choice for Cryptococcus neoformans is isoniazid, amphotericin B, ketoconazole, metronidazole and griseofulvine. Cryptococcus. I hope you know Cryptococcus is a fungus, and cryptococcal meningitis is a severe illness. Cryptococcal meningitis is many times associated in immunodeficient patients, especially the patients suffering with HIV/AIDS disease. So we need to choose an antifungal agent for this. If you look at the choices, they are isoniazid, amphotericin B, ketoconazole, metronidazole and griseofulvine. So you have isoniazid here, which is anti-tuberculous drug. Let's remove it out. We have metronidazole, is not useful in fungal infections. So let's keep aside. We have amphotericin B, ketoconazole and griseofulvine. Griseofulvine is mainly used for superficial fungal infections by systemic route of administration. So let's keep aside griseofulvine. Next is ketoconazole. What is ketoconazole? It's an azole antifungal, but it's an older azole antifungal. And ketoconazole is not very commonly used since we have many other antifungal agents available. And this way, we are left with amphotericin B. That has to be the right drug. But if we discuss this question in this way and go to the option amphotericin B, it will be injustice to the effective action of amphotericin B. Amphotericin B is the great agent. It's a broad spectrum antifungal agent, and it's very potent against very difficult fungal infections. So I advise you to remember amphotericin B as it is, that it's a broad spectrum antifungal agent and it's got nice penetration in the central nervous system. You can use newer azole antifungals to potentiate the effect of amphotericin B. You can use flucytosine to facilitate the penetration and reduce the dose requirement of amphotericin B. But please remember, Pauline antifungals, amphotericin B, acts by producing artificial pores in the cell membranes and very useful for cryptococcal meningitis. So that's question number 2, amphotericin B. Question number 3, out of the following drugs, which drug has got the most liability to produce peripheral neuropathy? You have diadenosine, zidovudine, stavudine, lamivudine and indinavir. You have 5 agents which are anti-HIV drugs. If you analyze it, you have diadenosine, zidovudine, stavudine and lamivudine from the same group. What is the same group? It's nucleoside reverse transcriptase inhibitors. Means they are NRTIs. And the last drug, indinavir, is a navir, which is a protease inhibitor. So leave out the protease inhibitor, obviously, because protease inhibitors have the important effects which are related to the lipid metabolism, glucose metabolism. So we are thinking of peripheral neuropathy, bone marrow suppression, peripheral neuropathy. is associated with the NRTIs. So we have 4 NRTIs: diadenosine, zidovudine, stavudine and lamivudine. Out of which zidovudine and diadenosine, the first 2 initial agents, they are more bone marrow toxic, and that's their most important toxicity. The last agent, lamivudine, is the least toxic NRTI, nucleoside reverse transcriptase inhibitor. So let's choose the middle one, that's stavudine, option C. And stavudine has got maximum propensity to cause the specific side effect, that's called peripheral neuropathy. Let's have a look at the answer. Yes, that's stavudine. Please remember henceforth stavudine, peripheral neuropathy. Next question, question number 4. Which of the following acts on motilin receptor? Motilin receptor. And if it acts on the motilin receptor, is going to lead to increase in the motility. And we have the options: erythromycin, tetracycline, norfloxacin, chloramphenicol and cloxacillin. Out of all these 4 options, this is a specific information and you need to know this. The drug which has got a specific action on motilin receptor is erythromycin, macrolide antibiotic, and is going to help to move the bowel. Is going to stimulate the motility by acting on the motilin receptor, and in this way erythromycin can be used in the management of diabetic gastroparesis. It cannot be used for a long time because slowly there is development of tolerance, but if you want to know the use of erythromycin based on its action on motilin receptor, then it's diabetic gastroparesis. So that was question number 4. Look at the answer and confirm it's erythromycin. Next question, question number 5. Most common adverse effect of colchicine is? I remind you, colchicine is a drug used in management of gout. Options are pulmonary fibrosis, diarrhea, dyspepsia, peptic ulcer and renal damage. Dyspepsia and peptic ulcer go hand in hand, and peptic ulcer is more commonly known with the NSAIDs, not with colchicine. So we'll remove dyspepsia and peptic ulcer. Yes, colchicine can produce toxicity, but it's not renal damage. It doesn't lead to renal damage, nor it has any effects on the lungs. It doesn't get deposited in the lungs and doesn't produce fibrosis in the lungs. Very common adverse effect, because they are asking a common adverse effect on this question, is as soon as you start colchicine, the patient gets a sensation of loose stools, and that's called diarrhea. So if the dose is a bit more, the person can suffer from diarrhea. So the answer for colchicine, most common adverse effect is diarrhea. Let's go to next question. That's question number 6. Which of the following is a 5-HT2 antagonist? We are in 5-hydroxytryptamine. Options: A. Buspirone, B. cyproheptadine, C. sumatriptan, D. ondansetron, and E is cisapride. Now if you look at the options, all of a sudden it comes to your mind that there are some drugs which are specifically used for some illnesses. Let's locate them first. A is buspirone. Where is buspirone? Buspirone is in the chapter of anxiety. It's an anti-anxiety agent, and it's a partial agonist at 5-HT1A receptor. So that's 5-HT1A. Down, cisapride and ondansetron. These 2 drugs, I hope you know, these are anti-emetic drugs, and most of their effects are related to the 5-HT3 receptor. 5-HT3 receptor. For example, cancer chemotherapy induced vomiting and the stimulation of 5-HT3 receptors. So that's ondansetron, and one more prokinetic agent, that's cisapride. Then you have your sumatriptan. Sumatriptan is the drug which is useful in the management of migraine, and migraine is not concerned with the 5-HT2 receptors. Again, it is 5-HT1 receptor. And we are left with cyproheptadine. Please remember the drug. It's got additional antihistaminic properties, and cyproheptadine is a 5-HT2 receptor antagonist. It increases the appetite, it increases the sleep, it decreases the irritability, and it is useful if any of the secretions inside the body is 5-hydroxytryptamine, which is raised or elevated, which happens in a condition called carcinoid syndrome, which secretes 5-HT, and cyproheptadine is useful to manage carcinoid syndrome. So cyproheptadine 5-HT2 receptors. This is your answer, cyproheptadine, for question 6. Question number 7. Which of the following is a non-competitive antagonist? I hope you heard the modules on general pharmacology, and you have also been hearing to other multiple choice question sessions, and we have discussed competitive antagonism and non-competitive antagonism at length. If you still have a doubt, or if your concept is not clear, then please go to these videos to have a look at the competitive and non-competitive antagonism. Many things might be clear forever. So the question is, which one is non-competitive antagonist? You have flumazenil, propranolol, phenoxybenzamine, atropine, and naloxone. Let's try to locate what is the drug against which this substance works as antagonist. Flumazenil. Flumazenil is an antagonist of benzodiazepines, also non-benzodiazepines. So flumazenil has got a competitive action, and benzodiazepines and non-benzodiazepines will be the agonist. So this is competitive antagonism. Propranolol is a beta blocker, so it's going to block the beta receptor. So it's a receptor antagonism, blockade of the beta receptor, and if any beta stimulant is given, there's going to be a competition for the same receptor. So propranolol is a competitive antagonist. Phenoxybenzamine is an alpha blocker, and its mechanism of action is little bit different. It combines with alpha receptor, no doubt, but it produces covalent bonding with an allosteric site, and so that the original site of the alpha receptor undergoes a modification, undergoes a change in the configuration, so that the alpha agonist cannot combine. So if a drug is combining at an allosteric site, same receptor but different allosteric site, then it's called as a non-competitive antagonist. So that's your phenoxybenzamine, is a non-competitive antagonist of norepinephrine. A rare example, that's why you need to remember the name phenoxybenzamine, an alpha blocker. Next drug is atropine. Atropine is anticholinergic, blocks the muscarinic receptors, and obviously it's a competitive antagonism. It's a competitive inhibition of the cholinergic receptor. And the next one is naloxone. Where did you hear naloxone? Naloxone is used in acute morphine poisoning. It's an opioid antagonist. It's antagonist at all the 4 opioid receptors. So again, it's a receptor antagonism which is of competitive type. So answer for non-competitive antagonist is your phenoxybenzamine. Let's move to the next question. Question number 8. Which of the following can precipitate acute congestive glaucoma? A drug which is likely to raise the intraocular pressure and likely to precipitate acute congestive glaucoma: pilocarpine, icothiopate, atropine, physostigmine, and propranolol. You have 5 options here. Look at the options. Pilocarpine, is it a cholinergic drug? Is it used for glaucoma? Yes, it's a cholinergic drug used for glaucoma, decreases intraocular pressure. Icothiopate is from the anticholinesterase agents, so it's again going to be like acetylcholine, so it's going to decrease the intraocular pressure. So this cannot be the answer. Next drug is atropine, which is anticholinergic, and this anticholinergic is going to have opposite action, is going to produce passive mydriasis and cycloplegia, and this will lead to crowding of the iris in the anterior chamber, and is also going to paralyze the ciliary muscle of the lens, which will fall in the anterior chamber, and this is going to produce precipitation, increase in the intraocular pressure. So acute congestive glaucoma is precipitated. I hope you remember your pharmacology. Atropine is contraindicated in acute congestive glaucoma. The next drug is physostigmine. This is again an anticholinesterase agent, so it's going to concentrate acetylcholine, is going to decrease the intraocular pressure. I hope you remember physostigmine in the management of glaucoma. Last one is propranolol, which is a beta blocker, and we don't expect it to precipitate acute congestive glaucoma because the beta blockers are supposed to have beneficial effects in glaucoma. You can resolve it at this point in time this way, and we come to the right option. The right option is atropine. Next question for you. Question number 9. Along with folic acid, the most appropriate specific treatment for pernicious anemia is. So it's about pernicious anemia, you want to give most appropriate specific treatment, and the question is saying that folic acid has to be given. I hope you know, if it's megaloblastic anemia, never treat it just folic acid alone. Treat it with folic acid and vitamin B12 both. That's going to be better, especially if there is B12 deficiency and you treat alone with folic acid. This is going to be harmful. So we are not in question about the folic acid now. Our issue is what is most specific treatment for pernicious anemia. You need to know what is the most specific pathology in pernicious anemia. Then we are going to come to the answer. What is pernicious anemia? Is the deficiency of intrinsic factor of Castle. That's why vitamin B12 doesn't get absorbed when you give it by oral route of administration. The intrinsic factor of Castle comes from the gastric peripheral cells. And if you put vitamin B12 in your stomach, then there's no intrinsic factor of Castle, is not going to get absorbed. Are you appreciating? So in pernicious anemia, there's no use of giving oral vitamin B12. Let's look at the options now. A. Initial parenteral and then oral vitamin B12. Because that's the usual way of treating patients, because now the condition is severe, you give it by injection, and by the time the patient can take it orally, or by the time the condition improves, you shift the patient to the oral treatment. So it's tempting you to choose initial parenteral and then oral. No, say no. Vitamin B12 given by oral route is not going to be absorbed because it's pernicious anemia. Second option B is folinic acid. Folinic acid has nothing to do in pernicious anemia. The deficiency is vitamin B12 and is specifically due to intrinsic factor of Castle deficiency. So folinic acid, no. Next one is parenteral vitamin B12. Yes, parenteral vitamin B12, right. This seems to be logical. This seems to be sensible. Next, oral vitamin B12. Straightway out. Oral vitamin B12 not accepted. And the last one, none answers apply. We don't need to choose it if you are getting a right answer among the 5 options. So the answer has to be parenteral vitamin B12. Always remember, anyone asks you pernicious anemia, don't start with vitamin B12. Please say the word parenteral. Injectable or parenteral vitamin B12. You're never going to go wrong. So this was your question number 9 about pernicious anemia. So that's the answer, parenteral vitamin B12. Next is question number 10. The most commonly used inhalational atropine substitute for bronchial asthma is. Most commonly used, see, you have to take care of these simple words. They appear simple, but it's focusing something. The most commonly used inhalational atropine substitute is. So you have to think about the atropine chapter and think, what are the atropine substitutes used in bronchial asthma? That's better way of solving a multiple choice question. Atropine is contraindicated in bronchial asthma. Did I say glaucoma by error? I'm sorry if I said it. We're speaking about bronchial asthma. Atropine is contraindicated in the management of bronchial asthma because atropine produces extreme dryness and there's formation of thick tenacious mucus plugs in the respiratory system, which adds to the discomfort. So we don't use, otherwise atropine is a bronchodilator. Now because of this defect, this drawback of atropine, we have newer substances which are atropine substitutes. They produce less dryness, they are bronchodilators, and they're always used by the route of inhalation. And there are 2 compounds, one is ipratropium and the second one is tiotropium. So if you have anything like this, it's going to be the right answer. Most commonly used inhalational atropine substitute for asthma is cyclopentolate, cyclamin, atropine methonitrate, ipratropium and scopolamine. So that's our answer. Ipratropium is going to be our answer. Cyclopentolate, I hope you heard. Cyclopentolate is an atropine substitute used in the eye, is commonly used in the estimation of refractory errors. Cyclamin is an atropine substitute which crosses blood-brain barrier. It's got additional antihistamine properties. Next, atropine methonitrate is an antispasmodic atropine substitute. Ipratropium we are considering, and scopolamine is another atropine substitute, and I hope scopolamine is available as patch and it's no way concerned with bronchial asthma. So the right choice for this last question, question number 10, is going to be ipratropium. Is used by inhalation. It's a bronchodilator and mechanism of action is same as atropine, is going to block the muscarinic receptors. So this was rushing through 10 important multiple choice questions, high yield questions, to go in different chapters to discuss the concepts. I hope you enjoyed it and it also benefits you on your examinations. Keep up your good study and best of luck.